disturbing. Something was going on. What we found was that Indonesian physicians were concerned that there was not enough high technology care to offer at the end of life, that many people that they were caring for who died should not have died, whereas the American physicians were dealing with a reverse of that problem where there was futile treatment and excessive use of care. And I think that really characterizes the issue quite clearly. The critiques about questioning care were very similar to the American version as well. And again, the Indonesian physicians were very likely to question care more highly than were the Americans, statistically significant. They felt there were more problems with the care that they were observing, and it was very vocal. One of the things we found was that the junior doctors were very angry at the senior doctors. They felt that they were abandoned by the senior doctors. Now this has something actually to speak to medical education and medical training. So the residents felt they were being dumped on, patients were being dumped on them, care was being dumped on them, and that their attendings were not present. They weren't there to consult or oversee or supervise. When you take a look at these issues, the typologies of errors that were identified by these groups, errors in judgment are much higher amongst the Indonesian physicians and errors in technique than among their American counterparts. On other things, they're very similar. I will end with just a few quotes. Let's look at communication. We felt uncomfortable criticizing them, but they know more than we do. They're experts in the field of female attendings and about people in the ICU. So the culture here is different in terms of the culture of practice. We have to really be careful about what you say. The judgment and lack of patient and family resources, this is very interesting. We found American physicians saying the same thing. Why are you doing this test at the end of life and spending this money? This is like, you come to the hospital and say the Brigham and you go, it's like going to Disneyland, you go on all the rides. Here we find, okay, you're going to Sarjito, you're going to go on all the rides and all these tests are going to be done and not beneficial. Issues and problems with teamwork, with your colleagues, with technique that was used, with communication and systems of training. One resident said, you may get blacklisted by the staff if you can't handle a patient, if you say you need help. Concerns about financial resources, limitations of health facilities also came up. 37% of recent patient death narratives and 43% of the most emotionally powerful death narratives included tales of error and poor quality arising from lack of resources. I will conclude. What are the differences between Indonesian and American physicians? I think very small in terms of culture, knowledge, but not necessarily in terms of practice. There's a universal culture of medicine. These clinicians are tough. They are managing emotional neutrality. And the responses, I think, represent a difference in resources and a difference in the practice of responsibility between seniors and juniors. So Indonesian physicians, as I said, are concerned with too little care rather than with excess futile care. And they also are identifying their issues and problems and concern with the competition from other Asian medical systems like Malaysia and Singapore, and how they improve the quality of their care. And the nice thing about this study was that it changed the practices in Sarjito Hospital. The people we worked with were really powerful people, and they were able to actually institute change that improved the quality of end-of-life care. And I'd like to end there. There's so much more to talk about, but I
So where have we been? We've talked about the rise of medicine and the role of medicine as a part of modernization in this part of the world. Mary Jo's talked about the complexity of that in the area of high technology medicine, where increasingly high technology medicine is available, but in which physicians often read all the same journals that Americans do, but know that there are certain things they can't do, and know that their patients can't afford certain things, and therefore have to live both in a world of high technology medicine and at the same time of scarcity. And the third example that I want to just spend a very few minutes talking about is the area of mental health care. But I would say in some important ways, mental health care has been excluded from this story of modernism and the modernist project. For a very long period of time, persons have thought about mental illness as chronic, incurable, degenerative brain diseases, and have essentially placed persons with serious mental illness in big hospitals. Now, when mental health care was introduced into this part of the world in terms of colonial medicine, it had two characteristics. At the beginning of the 20th century, there was a notion that essentially major mental illnesses were untreatable, and the best way to treat people was to put them in big hospitals and big asylums. And asylums were brought not as native parts of healthcare in this part of the world, but were brought in. And very often, this was when we started working in Shanghai in 2000. What does it look like? Huh? It looks like a prison, right? Right? And that's what mental hospitals look like as late as 2000 in one of the most advanced mental health centers in China. These are the kind of settings. It's clean, but it's also incredibly crowded. And it reminds me of when I was young and first would go to mental hospitals in which they have a feeling of being like in a prison. This is actually in Bali, and it's an old Dutch colonial institution. Looks somewhat different. It actually also carries part of the sort of positive sense of being out in gardens, etc. And the Balinese, of course, do what they do. They put shrines. They turn it into a kind of Balinese religious shrine at the same time, linking up more traditional forms of healing with the medical center. Now, in Indonesia, where I work, ideas about if you go into the community and ask them why somebody has had a mental illness, they don't usually begin by saying it's a brain disease. They usually say that there's been some kind of spirit, ada kejawen. Kejawen there means Javanese black magic being done to you, etc. And very often, the pharmaceutical industry thinks the best thing is you should correct these ideas and tell people what's really true. This is a brain disease. I always say, no, it's actually much better to have an idea that you're being attacked by some kind of black magic, because then there's something we can do about it. And there's actually hope that we can get better. Now, in Indonesia, and I'll show you a few slides about this, there's a tremendous problem that comes out of this long history of considering mental illness to be neither very high priority nor something that is high prestige. So as Mary Jo, you've heard the stories, there's a lot of prestige associated with high technology medicine, and there has traditionally not been much prestige, I don't know about here, but much prestige associated with mental health care. There's been profound stigma attached to mental health care, And that varies by society, but it's certainly true in East Asian societies. And there has not been a tremendous amount of investment in mental health services. This is just a reminder of the kinds of resources that are available. So that in Australia and the United States, there are about 14 psychiatrists per 100,000 people. In Singapore, where we just came from, it's only 2. In Malaysia, it's less than one. And if you look down in Indonesia, where we are, it's even 1/3 number of psychiatrists per population as compared with here. So one begins having to think about how do you modernize a mental health system with that kind of extraordinarily limited resources. The same thing is true in an interesting way with mental health beds. What do you notice about this table? One thing. The Japanese have more psychiatric beds per population than anybody in the world. And they have the longest hospital stays of anybody in the world for persons with serious mental illness. That's a whole story of its own. But if you also look at that, what is interesting is that Singapore and the United States are about the same, and I would say Hong Kong is about the same, but they came at it from a very different way. I'm going to take you right to this slide. This slide shows that over the last 40 years, there has been a major movement in Western mental health services toward deinstitutionalization. That is, toward closing down of big psychiatric hospitals and moving mental health care into the community. So that, for instance, if you look at this was 1960, right? America had 4 hospital beds per 1,000 people in the mental health area. And with the deinstitutionalization movement that Mary Jo and I remember when we started working in a psychiatry department, one had a radical reduction in numbers of beds down to what is currently the case in the United States. Here is the interesting, very different case of Japan that was going in this direction. But in a way, much more relevant is this is a case of Korea that began much lower, and by the year 2000, was about the same number of beds. So they're coming from very different directions. I was invited to talk to psychiatrists in Hong Kong about the question of should big hospitals there be closed. And it's very fascinating to simply begin with the acknowledgement that there they began with almost no services, no hospitals, and gradually built up. The Americans began with clearly far too many and ended up with in about the same point. So, but just a word. Over the last 4 decades, there's been a pharmaceutical revolution that has changed mental health care. There's been a deinstitutionalization movement with movement of resources and the patients back into the community. There's been a mental health reform movement and a movement toward recovery-oriented mental health services. And a lot of this has been based in some of the very best models of care. I won't take you through this now, but Italy has